Educational content by Dr. Mohammed El-Nagi Mohammed. All right, let's jump right in. We're going to do a high-yield clinical update on a really common and, let's be honest, often challenging condition, chronic prostatitis.
Okay, first things first, we've got to be precise with our language. Clinically, we've really moved beyond just calling everything chronic prostatitis. The modern, guideline-recommended term, and the one you absolutely need to know for your exams, is chronic pelvic pain syndrome, or CP/CPPS for short. And this isn't just semantics. This shift is so important because it reframes the whole issue. We're not just talking about an inflamed prostate anymore. We're talking about a complex pain syndrome. That helps manage patient expectations right from the start.
So, what's the official definition of CP/CPPS? Well, there are two key parts. First, the patient has genitourinary pain that's been going on for at least 3 months. And second, this is the critical part, there is absolutely no evidence of a urinary tract infection. Now, you might think this is a rare diagnosis, but it's not even close. It is, by a huge margin, the most common form of prostatitis, making up over 90% of all cases. Grasping that statistic is vital, both for your clinical practice and for the MRCGP AKT.
All right, so how do we actually get to that diagnosis? Let's talk about the diagnostic approach. A structured workup is everything here. Our main goal really is to confidently tell the difference between the non-bacterial CP/CPPS, which, remember, is the vast majority of cases, and the much rarer chronic bacterial prostatitis.
So, this breaks down into 4 key steps. First, you need a really focused history. Using a validated symptom score like the NAIJ CPSI is a great idea. Second, a physical exam, which has to include a digital rectal exam, a DRE, to actually feel the prostate. Third, and this is completely non-negotiable, you have to do a urinalysis and a midstream urine culture to rule out that active UTI. And finally, in some very specific cases, you might think about cultures after a prostatic massage, but we'll get into the details on that in a bit. The main point here is that this step-by-step approach lets us build the case for CP/CPPS by carefully excluding everything else.
Okay, let's switch gears to management. We're going to start with a topic that comes straight from our source material and is just full of clinical nuance: antibiotic therapy, and specifically the role of quinolones.
Our source text says, a prolonged course of a quinolone is often recommended. Now, this reflects a very, let's say, traditional way of thinking about prostatitis. But in modern practice, we have to really stop and critically evaluate a recommendation like this. Let's break down why.
So this is where it gets really interesting, the huge gap between the old rationale and the current reality. I mean, the rationale made sense on paper, right? Quinolones get into the prostate tissue really well, and they cover a lot of different bacteria. But the reality, based on the evidence we have now, is totally different. In non-bacterial CP/CPPS, and let's say it again, that's over 90% of cases, their effectiveness is pretty low. And even more importantly, regulatory bodies like the MHRA here in the UK and the FDA in the States have issued some pretty serious safety warnings about side effects. Throw in the problem of rising bacterial resistance, and you can see why just handing out long courses of these is no longer a good idea. So what's the take-home message for your practice today? It's this: antibiotics have a very limited and specific role. A short trial, maybe 4 to 6 weeks, can be considered. Think of it as a combo diagnostic and therapeutic tool, just to rule out some hidden or occult bacterial cause. But, and this is the key, you have to have a clear stop point. If you don't see any real clinical improvement, that antibiotic needs to be stopped promptly. Giving long-term or repeated courses to a patient with confirmed, non-bacterial CP/CPPS just isn't supported by the evidence, and it puts them at unnecessary risk.
Now for the second management point, which also comes straight from our source, prostatic massage. This is a perfect example of a debated intervention where you really have to look critically at the evidence base, or lack thereof.
And again, the source is actually very direct about this. It says there has been some debate, though no conclusive data published to date. Honestly, that statement itself is a massive clinical takeaway. It's basically signaling a huge evidence gap, which means we have to be incredibly cautious about recommending this as any kind of routine therapy.
And this table just spells it out perfectly. Let's just walk through it. The proposed mechanism, the idea that it drains blocked ducts, well, that's purely theoretical. Then when we look at efficacy, the evidence is consistently rated as inconclusive or just low quality. So as you'd expect, its role in major clinical guidelines is pretty clear. It is not routinely recommended as a treatment for CP/CPPS. Sure, some patients might say it helps them anecdotally, but as a therapy, it's just not grounded in any solid clinical trial data.
Okay, let's pull all this together now.
These are the high-yield, bottom-line points you need for your daily practice and for tackling any questions on the MRCGP AKT.
Number 1, chronic pelvic pain syndrome is the diagnosis in more than 9 out of 10 cases. 2, it is a clinical diagnosis of exclusion made after you have ruled out an active infection. 3, quinolones are not a go-to long-term treatment. You save them for a limited diagnostic trial, and you are always mindful of the safety alerts. 4, prostatic massage is not an evidence-based, routinely recommended intervention. And number 5, and this is probably the most important part, your management focus has to shift to multimodal symptom management. We're talking about things like alpha blockers for urinary symptoms, anti-inflammatories for pain, specialized physio for pelvic floor dysfunction, and psychological support for the chronic pain itself. And a huge part of this is managing patient expectations about what this condition is and what we can realistically achieve.
So we'll end with this question for you to really think about in your own practice. Since we know the evidence for any kind of cure is so limited, how can we best shift our clinical focus? How can we effectively put together a plan for multimodal symptom management? And just as important, how can we provide the validation and support that these patients with chronic pain really, truly need? That right there is the modern challenge of managing CP/CPPS.